So, as I say, in a moment, I'm going to pass over to John and Julie. And in fact, I'm going to, first of all, ask John to introduce himself, and then Julie in a moment. And then we'll start the presentation properly. So, John, perhaps you could just introduce yourself.
Okay, thank you, Martin. Well, good afternoon, everyone. My name is John Weller, and I'm head of the Community Services team at Voluntary Action within Kent, and it's my responsibility to deliver the patient peer support pilot and also for the evaluation.
Thank you, John. And I'm also now going to pass over to Julie, our first presenter, who's going to start off today's seminar. Thank you, Julie.
Thank you, Martin. Welcome, everybody. Thank you for joining this webinar. My name is Julie van Rijkenveld. I'm a Principal Associate at South East Commissioning Support Unit. I lead particularly on patient and public participation and insights and feedback. And I'm the Programme Lead for the Patients in Control Programme in the South region, and also a similar programme in the Midlands and East of England regions. And that's...
thank you.
So just to give you some context, in this slide you'll see down on the right-hand side the transforming participation in health and care. Hopefully this will be very familiar to many of you. This was an online resource from NHS England that talks you through the statutory guidance on patient and public involvement and putting patients in control. So there's two elements. One is the patient and public engagement and involvement that we perhaps are more familiar with, and the other is the individual element of how to really put patients at centre stage of their own care. And a key commitment in that guidance was to establish a field force by region to provide support to CCGs and area team commissioners and to raise the bar for them in both of those areas. So our Patients in Control programme, as I say, we had two complementary programmes. We were successful in our bids in both of those regions. We started in the South first, and they went out a second time for applications in the Midlands and East. So the South was already started and beginning to develop its learning before we had the Midlands, so we could build what we did in the Midlands based on what we'd already experienced in the South. And the focus was very much on supporting the CCGs and area teams and working with them to explore and demonstrate the benefits of personalisation and self-management for a range of people that are involved in both health and care, from patients to all of those other providers. And the aim was for patients to become more active partners in both influencing self-management approaches at a CCG level, but also we would hope that the outcome from that was that it would impact on individual patients. If we were looking at the sort of overview of what was important and started commissioning and providing differently, then the ultimate aim was that patients individually would experience something different from that. So our programme, we were asking, so whose health is it anyway? We knew that self-care support and intervention can be far more effective if everybody that's involved in both commissioning and providing actually engages with the patients and carers in understanding what's important to them from their perspective. So we know that commissioners, of course, do their best to commission the most successful approaches for people to manage their own conditions. But we also know that we've heard that patients maybe think that what they need is slightly different. So we had existing insights of what patients and carers said was important to them, and our programmes wanted to build on that existing knowledge. So if they'd already told us what was important, and this was based on some in-depth interviews we did back in 2009, so we wanted to go back out and check whether it was what was important to patients and carers was still the same, or if it had changed, or if there were other themes. So the baseline for both programs was to get further into what was really important to patients and carers, and from that create mechanisms for co-designing future services, so that we worked with CCG early adopter sites, we called them. So the CCGs who said that they were interested in working with their local people to explore some of that insights work in more depth and at a local level, and actively involve patients and carers through the programme, so that we could have patient and carer leads, if you like, who could continue to influence that culture and behaviour change. So those are our key areas of activity, and this next slide shows a little more detail, puts a bit of flesh on the bones around what we actually did. So as you can see, I've got a South Region column and a Midlands, East of England column. The deep insights, we had over 900 responses from the South and nearly 300 from Midlands. And what that generally means is that the online survey asking what was important and what the priorities were, we've got over 1,200 responses. And the responses were similar, irrespective of geography, demographics, condition. So those deep insights that will be published are usable and applicable across any area. So it might be of use when looking at doing similar work in any local area. We followed up the online survey with follow-up telephone interviews, and as you can see, we did over 100 telephone interviews across the two regions to get more of that qualitative information about if a certain thing was important, why was it important, what did it really look like. And then out of that, we draw down to much more in-depth case studies that took place over a day's interview with these 6 individuals, and also videos from that. So again, all of this will be publishable. With that, you can see in the South region, we ran some facilitated groups at individual CCG level that only involve patients and carers. And we facilitated some groups with voluntary organisations. So there were 2 different models there. The learnings from those was, it was fantastic to involve the voluntary organisations. It was much more powerful if we involved the commissioners right from the beginning. So you'll see that in the Midlands, we jumped straight to those facilitated co-design groups. And in total through the programme, we have about 16 case studies of how CCG commissioners, literally sitting around the table with patients and carers, and in many cases voluntary organisations as well, really has made a difference in the thinking and development around commissioning. And the ultimate of all of this is being pulled into a resource pack that will be online and will be available on that site. We're desperately pulling all of that together at the moment, but we're hoping to have it pretty much there by next week. What patients and carers told us, you can see in front of you a list of things that patients and carers said was really important to them. There are 2 that you can see are clinical areas, but the others are the things that aren't rocket science. And these are the things that we found when we did our in-depth interviews in 2009. So the good news is it's still the same issues. The bad news is it's still the same issues. So for example, personalised care plan, highly rated amongst people in the surveys and interviews, and seen as something that would really help them to be in control, particularly if they were involved in developing it. But we know that there's still only about 3 to 4% of people that actually have one. These are some of the examples of those CCG co-design early adopter sites in practice. So again, from some of those insights of what was important, you can see that individual CCGs have localised it, thought about what was important to them, and you can see Brighton and Hove have been looking at a peer support framework. New Devon, Torbay and South Devon have looked at social prescribing, and Crawley and Horsham and Mid Sussex CCGs are involving patients in personalising care plan for patients with diabetes. There are other examples, but that's just a flavour. So moving on again, so this approach was adopted in West Kent, and they've been meeting for a year now, the Commission are working with local patients and carers to really look at what was important for them locally. And one of the members of the group, Viv Lyons, is on the call, so she will be supporting me in the Q&As. And through the facilitated meetings, the group has created guidelines of good practice in patient-clinician consultations. So if the end bit of this is what's the individual person's experience, then the patient charter is what we would expect in that consultation, but also what I, therefore, as the patient should consider when going into that. And the plan is that that will be built into future service specs. The other area was a personalised life plan. So again, the conversations were very much about I'm me, not the condition. And therefore, there are other things that should be taken into account when looking at what helps me manage my own health and sense of well-being. So it introduced all of the important areas of social interaction, leisure pursuits, and looking for emotional support. And that plan was built into the spec for an electronic care plan management system and is still being refined so that it will be built into the next stage of cascading that out. And then the other area that was developed was a peer support model. This came out of, one of the findings was about the importance of non-medical intervention. The more we looked at that, the more it was drilled down into, well, a key element of that covers not only non-medical, but also emotional support, is this peer support. So the group created this model of what was important from their perspective. And so this was where we've arrived, if you like. The group, with Commissioner involvement and agreement, identified this as a priority area, created an outline model for testing in practice, proposed this be at GP practice level. We had some interested conversations about where do you start? Peer support is huge. Which group of people is it for? Is it on? Some people might not want face-to-face, so it might be online. Some would appreciate one-to-one, others would appreciate group. So we had to keep distilling and refining until we could create something that we could at least go out and talk to GP practices about. We identified that if we suggested that it was at GP practice level, one of the things that we keep hearing is that commissioners and others want to know what the evidence is for different solutions. And if we're trying to create something new, it's quite difficult to evidence the impact and the value. We thought, therefore, that if we did it at GP practice level, we had a tangible, focused cohort, and that practice could also then do their own internal monitoring of has it made a difference in relation to attendance at for GP meetings and so on. And part of the development was that it be supported by voluntary organisations, recognising they already have the expertise in the field, and it would bring an element of governance and supervision and support. So we put in a bid and were successful to the other Patients in Control programme in the south, and the model is now being piloted in 3 GP surgeries, and it's being coordinated and facilitated by Voluntary Action within Kent. So that's my part.
Thank you, Julie. Thank you very much. That's great. That's a really helpful introduction to the background, the setting up, and the bigger picture stuff you've done as well. Which did you say, was it about, how many responses did you get from the survey? I've forgotten again already.
Over 1,200.
That's right, it was, wasn't it? Yeah. So it's a pretty big sample size. So in a moment, after the questions and answers, which we can ask Julie, we're then going to ask John Weller from Voluntary Action within Kent to talk about the practicalities, the differences between the three different groups that have been set up in three practices, and some of the learning from that as well. But before we do that, and I will actually ask John to join us in terms of being available on the microphone. But before we do that, we've got a little bit of time for questions and answers. So you can either type those in the chat box if you want me or or Julie to kind of read them out and respond, or you can just raise your hand and I will scan the list and ask you to ask your question. So primarily for Julie, because we'll hear more about the practicalities from John in a moment. Any questions for anybody? How it was set up? Anything at all? And we're waiting eagerly here. David, and then Jeanette. I might not be seeing these in the right order, but David, I'm just going to unmute you. What's your question?
Thanks. I was interested in getting a sense of the conversations with commissioners when you said that literally patients and voluntary groups sat around the table with commissioners. Just get a bit more of a sense of the sort of the detail of that and some of the issues it threw up.
Thank you, David. And although I know this, other people don't. You work for a CCG, is that right?
That's right. Sorry, I should have introduced myself. I'm the lay member for patient and public involvement on the Isle of Wight CCG.
Great, thank you. I'll just put you on mute again and see if Julie would like to respond to that.
I wonder if Viv could come in on this as well a little. We worked with the CCGs who were, we went out to all the CCGs and said, this is what we're doing, we'd be really interested in working with you. So given that it was quite a short time-limited project, we worked with the CCGs who expressed an interest in being involved with us. So West Kent was interested because they had self-care and self-management as core for their 5-year strategy. So the commissioning lead for that was keen to come to the table. So I think we started with an open door. I think there is an important issue about it does need to be facilitated. And I think A, to help the flow of the conversation, B, to help ensure that the patient and carer is heard, but also to give the space for the commissioner to be actively listening in the session. Viv, I wondered if you had any reflections?
Absolutely. I think it was very much like that. I think from a lay point of view, which I obviously that's where I'm coming from, I think that it was all of that. I do think at times that, or what I would suggest perhaps going forward with this, is that it doesn't necessarily always come across as a layperson that there is that open door. Yes, you're aware that there's a strategy there, but it's not always manifest. I think because there's so many competing priorities and interests, that actually the CCG perhaps is able to take things into practice and really champion this, so that although now we've got the 3 pilot studies going on, and as Julie said, you're looking for evidence. It's a catch-22. You're looking for evidence before you start, and that's clearly a very, very difficult thing to achieve. And I wonder if there's a possibility, maybe you could say something about this, who raised the question, is that an understanding somewhere that actually you've got to perhaps sort of invest both in terms of time, prioritizing, as well as actually potentially focusing a bit of money into getting pilots started or trials started so that you can provide the evidence further on. Is there any way that actually CCGs could perhaps be rather more proactive in taking that on?
Martin? Hello?
Hello, is there anybody out there?
I think...
Yes, yes, here we are. There is somebody out there. He forgot to take his microphone off mute. So I'll say that again. Thanks for reminding me. You could tell my lips were moving somehow. I'm going to just pass back to David, if I may, just to kind of respond. You're from a different part of the south of England, Isle of Wight, I believe, CCG. So I'm not sure Viv was posing a challenge, but there was a sort of polite kind of questioning challenge there. I think it'd be interesting just to hear how you might respond to that, David, before we then pass on to a final question before we move on. David, have you got anything to respond to?
Sure.
Like to say?
Yeah, I can concur and agree wholeheartedly with the sentiment that investing in pilots makes a great deal of sense, because it just makes things tangible and understandable. Because I think you have quite a lot of individuals who are willing to engage in this stuff, sort of commissioners day to day, but you just don't really know where to start sometimes. So you end up with patchy work across organisations. I'm not just talking about mine, I mean from what I've witnessed. And it's not until a few people get the backing to do something a bit different that it then becomes apparent to others in the organisation what they actually could be doing. And that's the kind of approach we've had on the island. And we're still slowly getting there, but we've got a sort of a pilot project that's bigger than a project now called My Life, a Full Life, a way of doing things that is slowly evolving good practice. But it required investment, and the main bulk of that actually came from specific funding to make it happen. But yeah, I think organisations need to, if they're generally committed to this stuff, need to find money either out of their own resources or grant funding to do this different stuff.
I think...
Final word then. Was that Julie coming in? And then we'll pass over to a second question. Thanks.
I think you're right, David. And in the Midlands, we've been doing a range of development sessions with top teams from CCGs. And this does come up. It's how can we disinvest in order to create these new approaches? And I think for me, one of the key things is the important thing to me is about getting around the table with patients and carers. So part of the justification, at least, is patients and carers have said this is what's really important, and what they're saying is really important isn't hugely expensive. But if we do test it, then we're showing that we really, really are listening to our local populations. And if we do the bite-sized bits, closely monitored and still in discussion with the patients and carers, we would hope that we can demonstrate that by listening, it's more appropriate for patients so that the uptake is better, for example. I do think the national policy is beginning to help drive this as well. So the 5-year forward view, Better Care Fund and all of that good stuff. I think there's something about locally, if people could just take a little bit of the risk, but absolutely work with patients and carers and run or walk slowly in tandem with the national imperatives that are coming along. But it is a bit of risk-taking.
Thank you very much, Julie. And we've got time just to, I think Jeanette's still, I hope still keen to ask a question. Jeanette, could you just introduce yourself and then what would you like to say or ask?
Yes, hello Martin. My name's Jeanette Ward and I chair the patient participation group in Bearsted in Maidstone. My question is along the same lines really, but I think I get concerned about new projects if GPs are kind of not involved in it. And I just wondered whether GPs were part of the original projects, and if they were there any particular issues that they raised?
Could you be a little more specific by what you mean by projects?
The actual patient peer support that you've been doing.
We're talking about.
The pilots we're talking about, sorry. Were they involved in them in any way?
So from the work we did from the group, we created the carers and patients with the commissioner created the proposed model.
Right.
And this was taken at, first of all, the commissioner went out to all the GP practices and said, this is what we're doing, we'd like to test it in practice. So then practices themselves put themselves forward as maybe interested. and then we went out to the practices to talk them through the model. So it was a process of filtering down to the 3 that then said they really wanted to test it in practice.
Could I add to that as well?
John, yes, and then in fact, John, we will smoothly move over to your presentation when you've...
Okay, sure.
So
just to, if I could just start on the practical level with that, Jeanette, we're looking to commence in Bearsted in a few weeks' time, actually. But just to say, originally when I was scoping the idea with the other practices that we're running in so far, so that's Wateringbury and I'm so sorry. So that's Wateringbury and Kingswood. We met with the GPs, the practice managers, and the chairs of the PPGs, and they were very much on board and very supportive of the idea of support groups. And then similarly met with the practice manager at Bearsted, and it was relayed that the GPs were in support of the support groups.
Okay, thank you, John. So there'll be plenty of time for more Q&A after John has kind of gone through his half of the seminar, part of the seminar, which is to explain more about the practicalities. And as you can see, John is from Voluntary Action within Kent. So over to you, John.
Okay, thank you, Martin, and good afternoon again, everybody. So first of all, just to give you a little bit of background behind Voluntary Action within Kent, and then really just to take you through if you like, the nuts and bolts of what we've delivered so far, which is over a relatively short period of time. But as I say, I'll explain as we go through a bit more, and please do feel free if you've got questions at the end. So Voluntary Action within Kent, we're a charity originally formed in 1964, so we've got 50 years of service delivering services, solutions, community-based led projects across, originally we started in Tunbridge Wells, but we're now delivering projects and services across the whole of Kent, Medway, and very recently in East Sussex, where we're delighted to be delivering young carer support services. Our client groups, we provide services and projects for children, young people, those living with disability, older people, and numerous other ranges in between. So we pretty much have experience of delivering projects for all manner of client bases and all different sort of areas within communities. On top of that, we also provide infrastructure support for the wider voluntary and community sector. So that's volunteer brokerage services, and then also support, advice and guidance to other organisations, which includes training, it includes setting up community groups and charities, and areas to do with governance. So we've got a good long track record of, as I say, delivering community-based projects involving and working with the communities that we serve. Just very briefly, I won't dwell on these too much, but some of our more recent projects that we've delivered, working specifically around sort of health and social care. We've delivered health trainer champions across North Kent. So that was recruiting volunteers, having them trained in public health awareness, and they would act as informed friends in various targeted communities where there was health inequalities, to help people to better manage their own health with regards to things, whether that was diet, smoking cessation, and so on. And that's now the health trainer project is now running across the whole of Kent. SAFE is a mental health awareness raising project. It's peer-led, it's run for young people by young people with the support of our project coordinators. Care Navigator provides services for older people, helping them to remain independent in their own homes. Delta Drive, community transport service. Key priority there is for medical appointments, helping to reduce social isolation. Two of the larger projects is Kent Young Carers and East Sussex Young Carers, where we provide support and respite for young carers between the ages of 5 to 18. And our Cameo project, again, a peer-led project where we recruited older people who were living on their own, socially isolated, bring them together to form support groups to build friendships, reduce social isolation. So again, all projects where we've involved volunteers, and that's the golden thread running through everything that we do, is the use, development, support, and supervision of volunteers to help us deliver all these services. So, moving on then, and following on from what Julie has said, the need was identified, and there was a clear desire for people to have access to peer support of some type. We explored a number of options, whether one-to-one peer support might be preferable with practice-based, and then we also looked at the potential for forming groups of people living with a similar condition. So talking this through and running by some different models, we decided to opt in the initial stages for a group support groups. 3 GP practices identified, that's Waterbury, Kingswood and Bearsted. So we commenced the programme in January, or the pilot in January, and they're running, currently the support groups are running at the Kingswood surgery and also at the Waterbury surgery. And Bearsted, as I say, will be commencing in April, so in a few weeks' time. It was a very, very, very short turnaround period for us to get it up, set and running. And our remit as Voluntary Action within Kent was effectively to design a programme looking to recruit the volunteers, considering the training that would be needed, facilitation of all the initial group meetings, and then looking at the general supervision and governance with the idea that the support groups would become self-sustaining and taking themselves further forward after the trial period. So I am currently putting together the initial 3-month evaluation. As I say, it just gives us a sample and a general feel of how they've been received in the 2 practices that we've been running them so far. And then starting in April, we've got further 6-month delivery activity with the pilot looking to be fully evaluated in September. It was initially identified that we would work with patients with similar long-term conditions, diabetes being the condition that was chosen. Really, from a practical point of view, the fact that each practice had a diabetes register, so if you like, there was already sort of cohort of potential patients that could be invited along. And the overriding idea behind it is that facilitators from within the group will be recruited and trained, and we have already identified some, and then they will take the running of the group forward from September. So basically, the remit for each group, the first thing really was that we wanted a group where people would feel welcome, reasonably informal, not too structured, where patients could come along and feel comfortable to be able to talk about their concerns, their issues, and really any areas of their life where they feel the condition has some sort of effect. I'll explain a little bit more there about the areas we looked at in a moment. As I mentioned previously, the idea is that each group will be facilitated by 2 peer volunteers. We have had some applications for that, and also we're finding that with the group that we've run so far, some people are naturally evolving into that role. So our role as Voluntary Action within Kent will be then to further provide training for those people with facilitation skills, managing volunteers, and running effective groups and meetings. We want to ensure that encourage greater and more effective self-management by people of their own conditions and of their lives, really, and their lifestyles. It provides a forum where people can discuss non-medical issues, and it's very important to mention there that the support group is not there to discuss clinical or medical issues, and it's really more to do with lifestyle issues, again, which I'll explain shortly. Another aspect to it is we wanted to provide people with more information of what wider support is available to them within the community. So whether that's carer support or whether that's other networks that they might be able to tap into that can provide information and support on a wider level. It could be community transport some people have taken up. I'll be giving some examples of the types of support people have taken up already in a little while. And then another key factor was a effectively provide social contact to people with a similar condition. And what we've seen so far, albeit not a great many groups have run, there really has been a fantastic and very enthusiastic embracing of this opportunity for patients to meet with other people with a similar condition. And it's become very apparent that many patients have been living quite isolated with their condition, and this has very much been welcomed and will be noted in the evaluation. The outcomes then that we want for patients from these groups: increased social connection, which we mentioned, self-management, improved and increased and effective self-management of their condition, improved access and awareness of the wider support that is available and that is out there for people. And I'm absolutely delighted to say that we've had already a good uptake of people getting involved in other activities associated through the support groups. And overall, there an increased sense of physical, mental and social well-being. So progress to date. So with Waterbury and Kingswood, we commenced the support groups in January, and we've been running 2 support groups for each practice per fortnight. Have found initially that's quite a commitment for people, but we've had good attendances and good numbers with some drop-off. So we are going to be moving from April with monthly meetings, and that's in response really to patients feeling that a fortnightly commitment is a little bit too much for them. Sessions, we found, again, we've run a lunchtime session for those who aren't working, and then also an evening session for those people who are working and unable to attend during the day. This has proved popular, with interesting generally the daytime meetings being more popular than the evening ones, but we will be continuing with those 2 options to ensure that it's as easily accessible as possible. We've had a very good take-up really between the two practices. So we've had 41 patients engaging altogether. The practices themselves have actually been quite pleased with the number of men that are attending the groups, as it has been noticed when they've held practice presentations and meetings in the past. Generally, they've seen a higher number of ladies attending as opposed to men. So that's been quite well received by the practices. With just some of the things that the spin-offs, if you like, that have occurred already, we've had 4 patients from the Waterbury practice already sign up to the EPP, which is the Expert Patient Programme, which is a 6-week course that helps them to come to terms and manage their condition better. We have a health walk leader who's been identified and is looking imminently to set up a health walk for the Waterbury practice. 2 support group facilitators have already come forward and said they've an interest and are keen to move the groups forward, which is great. Looking at wider support, 2 ladies from the Kingswood practice, and this is great, are now attending a regular monthly tea dance, which Voluntary Action Within Kent runs. And then similarly, we've also, one of the patients attending, his wife is now a retired psychotherapist and counsellor, and she's offering her services and coming along doing presentations looking to do with regards to the mental well-being and health of patients attending the groups. Right, very nearly there. Sorry, I'm just a flavour there. Obviously, the groups, we want them driven by the participants themselves, and this is really just the top topics for discussion, which we're arranging either speakers for or nutritionists to come along. And you'll see that diet and nutrition is the big one, and then followed by people becoming more active. Then we've got things like health walks. Insurance, interestingly, came up quite high, do with things like health, holiday, driving insurance, travelling abroad, managing stress and anxiety around the condition, fingerprinting techniques. So just a flavour there, really. I won't dwell on that too much. And then finally, I don't think my last slide's coming up there. Bear with me 1 second. No, it's not. No less. I will talk you through it anyway. So that's progress today. Topics identified. Just a little bit on the evaluation. With regards to patients, they all of those who have attended have completed quite a comprehensive pre-questionnaire, really, to determine what their current state is, how they feel about their condition, and the areas of life that it impacts upon. And then towards the end of the programme, further down the line, we will be doing a post-questionnaire, really to measure and identify the distance that they've travelled. We are monitoring the support group attendances and the demographics and the makeup of the groups. Any anecdotal evidence we're recording, so that's technically looking at increased patient activity or participation in other sites of support. We did mention this earlier, Julie alluded to this, we'll be looking at the level of GP visits by the patients over the medium and long term. It's too short a period of time at the moment to measure that effectively, but that's ultimately be one of the measures we'll be looking at. And then also be looking for feedback from the practice staff, GPs, and also for the patient participation groups. So I think that's me come to a close, and I think now if we can go for some questions and answers.
Thank you very much, John. So as before, but a little longer, of course, we've got about 15 minutes or so for questions and answers. They might well be for John initially, but obviously I'm going to make sure Julie's here as well to answer any that may require her knowledge as well. So we've had a really good joining up of the big picture, where the big piece of research that came up with the broad principles of what patients are saying they want, down to the really interestingly managed 3 pilots, which are going to expand, I think, as you say, and how they've been run and how they're different and so on. So I think there's going to be lots of interesting questions and suggestions as well. A couple of people are typing questions or comments actually as well in the chat box. It's probably best if you send them to everybody, because I think it's probably just a technical thing. If those of you who want to send a message or a question rather than speak it out aloud, just above where you're typing, you'll see a smaller box saying send to, and if you look in there, you'll see send to everyone rather than send to me. So that's probably, unless it is a message for me, so that would be quite helpful, and we can see those as they come up. So if there's anybody who's got a typed question or wishes to ask a question by raising their hand, please go ahead. There's a question from Bernard. And Heather's got a question, and Barry as well. I might not take it in the correct order, but thank you. Should we take the question which Bernard has typed in the chat box first, which I'll read out for you? Hi, as a former volunteer, patient and public lead in the CCG, we feel that patients have come up with great ideas on peer support, keeping this informal, not expert patient program, but have been stopped by CCG executives or ideas taken over by charity, I guess, larger charity providers. So there's a question here, provocative, good question for either of you, I think. How can patients become stronger to ensure that CCGs and new projects are led by real people? Thank you, Bernard. Anybody, Julie and John, either of you like to?
So, Martin, if I could pick up. I think it would be great if perhaps Viv could join in on this.
Please do, Viv, if you'd like to unmute yourself.
I think, again, the idea is that we're trying to demonstrate through our work through the early adopters, our work with Viv and other carers and patients, the value of working alongside. And I know that there is still quite a lot of resistance in the field for all sorts of reasons. We hear quite often that if we ask patients, we won't be able to respond to what they'll want. But as you saw from the priorities, actually, there's some fairly fundamental things, some things that wouldn't need too much input to make a significant difference. And I guess it's for all of us to just keep demonstrating that small steps can make a huge difference, and that working with patients and carers can be of real value because it actually brings your patients and carers on board.
Thank you, Julie. And Viv, would you like to answer? You've been invited by Julie there.
Absolutely.
Remind us again of your role. Or your...
My role has been as a carer to input into the group who's designed this that Julie presented on. And Well, hopefully, John, from what Julie and John have said, I hope that this is really inspiring everybody to take this on, because, I mean, this has been going for, virtually a nanosecond, and yet it's already achieved so much. So I do hope that people will be inspired by this. And of course, the question now is as to how it can be embedded, expanded to sort of continue in the real world, go on from a pilot to actually continue. So that would be my comment, and I do hope that, as I say, for understandable reasons, there's all sorts of other priorities. But I guess if I would end up by saying, really make this a priority, it is. I know it's about a culture change. It's also about investing to save, which is difficult because you've got to come up with the money first. But I think there will be huge savings, quite apart from the fact of the getting improvements in patients' well-being and so on. So I just hope that everybody's really inspired by it. But maybe if we could come back for those who are in the position where they could actually, as I say, embed this, take this further, maybe they've got some comments about how they can do that.
Can I come in again, Martin?
Yes, and then I'm going to ask, and then I'm going to ask Bernard whether he wants to say anything more, or whether he's got
because I think
the answer he wants. Yeah, Julie.
I think going back to what I said at the beginning, the field force was about two different areas. There's the one that we know around patient and public engagement, and this is something slightly different. But I think it would be great if CCG engagement people and lay members could think about those two different areas and bring this other bit into the arena, because quite often what we do is there's a service change. So we go out and engage widely about this is what we're doing, what do you think, which is great. This is more about continuing that dialogue with in a much more focused way. So looking at, for example, if you're doing diabetes, then saying, well, how are we going to start talking to our population and keep talking with them and say, so what would help you for it to be different? And it's a slightly different way of addressing that involvement. So I think there's a place for it in all CCG's existing engagement processes, as long as there's that understanding that there are two different bits. There's the engagement around the commissioning cycle, and there's the involving real people in real service design right from the beginning.
Thank you, Julie. And I'm just going to give, if Bernard wants it, the last word there before we then move on to two spoken and one written questions. If you'd like to, Bernard, or if that's completely satisfactory, just let us know. Unmute yourself if you want to speak. Bernard, I've unmuted you. Yes, Bernard, hi.
Yeah, hi, Martin. Thanks very much.
Do you want to just introduce yourself if you've got a particular role or background?
Yeah, so it's a split role. I've been a volunteer patient and public lead in a CCG, which I don't want to name. And I've also got a national role for Disability Rights UK, working very much on that same stuff. And one key thought I would like to share is the idea to really transform the system to help deliver peer support in practice. And I think we need to come around to perhaps making peer support an integrated element of commissioned care pathways across several conditions, so that people actually have a right to request peer support locally. I think that would be a great lever and would really create that sort of momentum that we would like to see, and also the support for proper local infrastructure to be built up. And the last point really is, I think we need to be careful to keep the informal nature of peer support. So if people talk about and call for evidence, I think there is a natural limit to that when we talk about peer support, because it really has at its core that it works informally when we tend to peer support us for support in our whole life domain.
Thank you, Bernard. I'm going to call that. That's really helpful, and I'm just going to add a last word before we move on to Heather Eardley. We've got just time for 3 more questions. Is that, of course, you'll know this, Bernard, as well as everybody else, that there's a difference between the research base that says peer support works, kind of end of story, it works in certain contexts better than others, and the informality of how it's organised, who organises, who's in charge of it. That's linked up, but it's separate from the research which is just there. We don't need to do any more to tell us it works. But I will move us on now. So we've got a range of questions. So Heather Eardley, if you'd like to introduce yourself. Hello, Heather. Hi, Heather. Heather, you're online, as they say, but I can't hear you at the moment. Heather? Hello. I'll leave that for now, Heather, and come back because we're not picking up your sound. But Barry, you also had your hand up. Barry Grimes, if you'd like to introduce yourself. What was your questionnaire and who was it for?
Hi, everybody. So I'm Barry, and I'm the Communications Manager at Bath and North East Somerset CCG. And finding this very interesting because we're currently looking at delivering a similar model for diabetes in our area. And what I was interested to know from John, he talked about the split between male and female in the groups. I was interested in the other demographics. Was he getting a particular age group coming along or a particular demographic within society, or was he finding it was quite balanced?
Okay. Yeah, thanks, Barry. Yeah. I mean, it was good to see the split, and the practices themselves both said they were delighted that they saw that there was a balance between more men attending. Predominantly, it is generally older people. However, there is a real cross-section of people as well. So it's not from any particular background area or location around the practice. There's a real mix, and that's actually worked really, really well. And I think after the initial session, it's great the way people open up, but everybody's been very, very welcoming to whoever then attends. So we had one mum came along with her teenage son, for instance, to one of the water and break groups, but they're bonding very well, but it is predominantly older people. I will have a breakdown of all of that for the evaluation when it's ready, but predominantly older people.
Okay.
Thanks very much. Can
Good.
I have a follow-up question to
yes,
that?
please do, Barry, please do.
It's just whether you'd looked at, particularly for maybe younger audiences, if you'd looked at having similar kind of forums but online.
We haven't looked at that yet, no, but I like the idea.
Can I just chip in there as well, because I used to lead diabetes improvement work in my local area, Bristol, and working with Diabetes UK as well. And we were very interested to find a model which was actually in the southeast of England, which was an online support group set up by younger people with diabetes. And there was lots of interesting discussion with the clinicians who I worked with quite a lot as to, that's not safe, but it's young people discussing what they think works. So there's a whole lot of interesting things about boundaries there. Worth noting as well. Julie, yes.
And again, we needed to start somewhere, and this is a time-limited project. So what we needed to work with the GP practices in areas that they were interested in. So they pretty much drove that diabetes was where they'd like to start. What we need is some of the evidence, and I'm hearing about the issue about the evidence, but some of this is the quality evidence, and it's the value to patients of different approaches. And the idea is that this is being monitored so that the commissioners are looking at whether, if we can see that there's a good experience and there's changes in behaviours, then they can continue to fund it. But obviously what we would want is to use that as the core for saying, but it should be all groups. And the model that was developed by the group initially was what they were proposing was to offer it to those people who were at risk of getting a long-term condition or who'd been newly diagnosed, because that's a very scary time. So, as I say, it's morphed because of the GP practices and where they wanted it to be, but it's only the start.
Thank you. We've got just over 5 minutes. I've actually got a very practical question from Laura. So I want a really quick answer, if I can, from either Julie or John, and then we'll a slightly longer question from Heather. I'll bring Heather in again. So Laura's question simply is, how much funding was provided from the CCG to set it up? Is there a simple answer?
If we're talking about the special interest group, then the facilitation was done through the Patients in Control programme, but the group is continuing post-programme, so the funding is coming from the CCG, and the funding is about travel expenses and hospitality. So the members are volunteers and are giving of their time. So it's out-of-pocket expenses.
Thank you very much. We won't carry that on anymore, but if there are more detailed questions, please just type them in the chat box, and if we can't answer them today, I'm going to ask Julie and John to reply, and I can send those responses out to everybody. So we've just got time, if it's going to work this time. Heather, you're online. Can you hear us? Can we hear you? Heather. I can hear some background noises, but I can't hear you, Heather, at the moment. Would you like to type your message? A poor substitute, but it'll be good. A good enough one. That'll be our last bit of the questions and answers. Whilst Heather is doing that, and I'm assuming she can hear me saying that, I've just wanted to is that you, Heather? No. Whilst Heather's doing that, I just wanted to point you to the ending of our seminar before Heather's message comes through. If you want to carry on this discussion, I think it's been very lively, and of course it could have been for a lot longer. Using the Patient Voice website is one way of doing that. So we've got a discussion forum which you can enter and take part in. Particularly, that works if you signed up as a member, which is just in the top corner of the website page. Easy to do, doesn't take a moment. You can use Twitter if you like. We'll follow you and join in that. But if you've got, this is a particular request, if you've got some resources that you'd like to share, whether it's a Word document or a web link or a piece of work or terms of reference, please just send them through to me on the email, Martin Howard. We'll put them into a little package and send them out to everybody who's been here today taking part. So that will form a resource pack which we can put on our website as well. And I do have Heather's question now, so although I will be her cipher and speak it out. What was the question is for Julie and John, what was the training for volunteers to roll out? And Heather works for the Patients Association, and she's saying we're doing something similar with patient participation groups, so she's keen to hear more about it. So the question there is about the training for volunteers. John, I think.
Sure. Okay. We're still identifying the volunteers to be the actual facilitators for the groups, but there's I suppose a short range of training that we will put them through. First of all, we deliver as an infrastructure organisation. We provide a lot of training and development for the wider sector anyway. So we have courses available, which are they're accredited courses on facilitation skills. So that's in particular making the most of meetings, community groups. So we'll be delivering that. Working and managing volunteers. So that's sort of around the structure and the theme of sort of supervision, structuring sessions, keeping things going and ticking over. And then really we have a range of different sort of behavioural type skills, which that training will be available for the volunteer facilitators if they feel they need any extra training on things. It could be like assertiveness training, communication skills, those types of options are available to them as well.
Thank you, John. Anybody got a question about the volunteer training, just to finish this off before we end the seminar? Any hand raising there or typed questions? I've got a question actually, John, just to say as we're nearing the end of the seminar, is around the volunteer training, because I've been picking up some really interesting information about a project that used volunteers with a mental health lived experience in South Devon and Torbay. Okay. And there's some interesting work needed to be done around supervision and barriers. Sure. Particularly you talked about this is not clinical intervention or discussion. How does that? Have you dealt with that so far?
Yes, that interesting. Actually, yes, I didn't mention that. Part of when we were establishing the groups, so anybody when they come along, if they're new to the group, we have effectively confidentiality agreements as part of the overall coordinating package that basically everyone has to sign up to. And yes, we've covered the issues quite significantly about boundaries, the fact it not being there for clinical or medical advice. I mean, that's not to obviously replace the GPs. But so people are very clear of that, and certainly with the facilitators when they go through the training, because currently I'm facilitating all of the groups at the moment, as and when we get the people come forward and actually trained up. But until then, I facilitate them, and yes, we have those clear sort of boundaries and guidelines, just safeguards really for everyone in place.
Great, thank you, John. So that answers some of the questions. There will still be more because there are 20 of us here taking part in this seminar, and I bet you'll be left with questions after this is finished. So just to bring us to a close and emphasise that today is just part of the work of explaining and spreading best practice around commissioning and patient and public engagement. So any questions afterwards, you may well have John and Julie's email address, but if you haven't, put them to me and I can put them to them. And this group of 20 or so of us, we can, for the next week or two, if you like, we can circulate amongst all of us, if you're happy to do that, or via me, any resources, ideas, information, or further questions. So it doesn't finish today in the same way that Julie and John's work doesn't finish today. So I'm just going to say thank you. I'm going to ask Julie and John to do the same, of course. As you can see on the final slide here, we'll send you a copy of today's presentation. We'll pop them on the website as well. And not today, because I think it would be good for you to think about it for a moment and let things sink in, but we will next week. I'll send you a very brief link to a questionnaire which will help us improve, if we need to improve these online web seminars. There's one more coming up. Take a look at our website. It's in April on an allied topic of the house of care and encouraging self-management. Again, some of that based around GP practices. So have a look at our website for the next web seminar.